Lifesavers, and welcome back to my channel. My name is Nurse Kelly Tyrrell, and in today's video we are going to continue our endocrine mini-series, and we're going to talk about probably the most common endocrine disorder that you are going to come across, which is diabetes mellitus. We're also going to cover some pharmacology and all you need to know about insulin management. But before we jump into it, make sure you subscribe to my channel, like, comment, and share this video with a friend, and make sure you click on that bell icon to turn on notifications so you don't miss out on any of my upcoming content. If you confuse the different types of insulin or you're unsure of the correct order to mix and administer them, then I suggest that you keep watching. Diabetes mellitus can be one of the most difficult disorders to treat because it requires the patient to completely change their lifestyle, their eating habits, and commit to a very strict medication regimen. So even just one day of missing their insulin or one slight mishap of accidentally double dosing their insulin can lead to detrimental and sometimes fatal consequences. So given the complexities of this disorder and the high-risk medication used to treat diabetes, it's a very highly tested topic in nursing school and on the NCLEX. Glucose is the body's primary source of energy. It's primarily received from carbohydrates and simple sugars in our diet, which gets converted as food progresses through our digestive system. And insulin is produced in the beta cells, which are located in the pancreas, and their primary role is to carry glucose into our cells, where it's then used to facilitate cell metabolism, aka it provides our cells with a lot of energy. So what happens when you don't have enough insulin to bind to that glucose and carry it from the bloodstream into the cells? Well, that's when you develop the condition diabetes mellitus. And there are three different types of diabetes mellitus. There's type 1, which happens when the beta cells are actually unable to produce any insulin at all. And then there's type 2 diabetes, where one of two things will happen. Either the beta cells can produce some insulin, but it's not enough to carry majority of the glucose from the bloodstream into our cells, or you have something called insulin resistance diabetes, which means that the beta cells are in fact producing a sufficient amount of insulin, but there's a disconnect with the insulin binding to the glucose and moving it from the bloodstream into the cell so that way it can be used as an energy source. A classic way to tell the difference between type 2 diabetes and insulin resistance is the patient with the insulin resistance will have a normal or high blood serum insulin level. And that's because, remember, it's not an insulin production problem, but it's a binding and transfer into the cell problem. But with both types of diabetes, when the patient's blood glucose level increases, the brain is going to send out increased thirst signals in an effort to flush that extra glucose from the bloodstream through the kidneys. So because of this increased thirst known as polydipsia, you'll also see an increase in urination, which is called polyuria. As the cells become more and more starved of glucose, the gut will also trigger those hunger signals to try and increase the glucose through an over-ingestion of food. If you remember the direct feedback process I talked about in my last two lectures, that happens also with diabetes. So as the blood sugar rises, insulin production is triggered, and when insulin fails to move glucose from the bloodstream into the cells, then the thirst and hunger signals are triggered to try and compensate for that lack of cellular energy. And patients who are diagnosed with type 1 diabetes, they're going to be insulin dependent, which means that they're going to have to inject themselves with insulin every day, sometimes even multiple times a day, usually through an implanted insulin pump. Type 1 diabetes is typically caused by the destruction of the beta cells, which is where that insulin is actually produced. And this usually happens from some type of autoimmune process at an early age. So you'll also hear type 1 referred to as juvenile diabetes. Patients who have type 2 diabetes may or may not need to be placed on insulin because the beta cells are still producing some of the insulin. So if the patient can lower their intake of those complex carbohydrates and sugar through their diet to match up with the lower production of insulin, then they may not actually need to inject themselves with any insulin at all. And the same also applies to patients who have insulin resistance. They may be able to control their blood glucose levels with a simple change in their diet, and it really depends on how resistant they are to their own natural insulin production. Patients with diabetes mellitus are at risk for many different complications, including vision loss, known as diabetic retinopathy, damage to the blood vessels and nerves, known as diabetic neuropathy, and also kidney damage, known as nephropathy. So this happens again because the cells rely on glucose for energy. So if there's not enough glucose being moved from the bloodstream into the cells, then the cells start to deteriorate. The good news is these complications can be significantly decreased if the patient follows a very strict low carb, low sugar diet, if they monitor their blood glucose levels frequently, and if they administer their insulin according to their blood glucose readings. All right, so now let's talk about some hallmark signs and symptoms for each of the types of diabetes that you'll want to be familiar with. We'll start with the symptoms that both type 1 and 2 have in common with each other. So in both types of diabetes, you'll see an increase in appetite, or also known as polyphagia. Again, because those cells are starved for energy. So because of the feedback process, your gut is going to send out more and more hunger signals. You'll also see increased thirst, called polydipsia, like we just talked about. Again, because the body is trying to flush out all the extra glucose in the bloodstream. And along with the polydipsia, you'll also see that polyuria, or increased urine, because what goes in must come out. And next you'll see frequent infections, specifically candida or yeast infections. And this is because the patient has all of that extra glucose circulating in their blood, which is a breeding magnet for bacteria. And the last common symptom that you'll see is the patient will have delayed wound healing, again because of the same reasons you'll see with the frequent infections. Okay, now let's talk about the specific differences between the two. So with type 1, you're going to see a very fast or acute onset because the beta cells will suddenly stop producing all insulin. You'll also see rapid weight loss, even though the patient may be eating more because of those hunger signals, but none of that glucose is being moved or stored into the cell, so they're gonna lose weight really rapidly. Now, with type 2, so you'll see a very slow, or also known as insidious onset, because you still have some insulin being produced and some of the glucose is being moved into the cells, but it's not going to be enough. And the patients with type 2 may actually be completely asymptomatic, and they're only diagnosed when they go for routine blood work, which shows that they have an elevated glucose level. And again, this is because there's still some insulin being produced and some glucose is still being moved into the cells. So your body does compensate for a little while. All right, so now let's talk about some common test results that you'll see. So the first test is known as a fasting plasma blood glucose test, which will show an elevated level of 126 milligrams per deciliter or higher on 2 different tests. Next is an oral glucose tolerance test. If it's positive, the patient will have a plasma glucose level of 200 milligrams per deciliter 2 hours after ingesting 75 grams of oral glucose. Next is a random plasma glucose test at or above 200 milligrams per deciliter in an asymptomatic patient. Next is the hemoglobin A1C test, which will be 6.5% or higher on 2 separate tests. Now, I will say that this test can be a little unreliable in patients who have dysfunctions involving their hemoglobin, like hemolytic anemia or iron deficiency anemia or pregnancy. So this test is not solely used to diagnose diabetes, but it can be a red flag indicator. And the last test you'll see is an increased glucose in the urine, which is also known as glucosuria. Again, this is not always a reliable test because the threshold of glucose in the kidneys varies from patient to patient. So once a certain glucose level is reached in the blood, then the kidneys will start allowing more glucose to filter through and be excreted into the urine. So again, this test will be used along with the other tests that I had just talked about to make a final diagnosis. So what treatments can we anticipate providing to these patients? Well, the first line treatments are going to be strict monitoring of the blood glucose levels, also administering insulin in an attempt to normalize that blood glucose, and also placing the patient on a low carb, low sugar diet, and encouraging exercise to maintain that ideal body weight in patients who have type 2 diabetes. All right, so let's talk about the pharmacological management of these patients, starting with insulin. So insulin is one of those very high-risk medications, and it has actually caused patient deaths due to incorrect administration. So it's really, really important that you know your insulin management in and out. So the first type of insulin is going to be your rapid acting insulins, which are typically given about 10 minutes before patient meals. So these are going to be your clear insulins, and they have an onset of 15 minutes, a peak time of 30 to 90 minutes, and a duration of 3 to 5 hours. Rapid acting insulins include Aspart or Novolog, Glulisine or Apidra, and Lispro or Humulog. The second type of insulin is short-acting insulin, which is used for short-term glucose control. So these, again, are going to be clear insulins, and they have an onset of 30 to 60 minutes. So you're going to give this about 30 minutes before meal times. They also have a peak time of 2 to 4 hours and a total duration of 5 to 8 hours. Short-acting insulins include your regular or Humulin R, Novolin, and Velosolin, which you'll see typically used in insulin pumps. And the third type of insulin is the intermediate insulins, which provide glucose control for about half of the day. So these insulins are typically given twice a day, and usually they are combined with a rapid or short-acting insulin. So these insulins are going to be cloudy, and their onset is 1 to 3 hours. The peak is 8 hours, and their total duration is 12 to 16 hours. And the most common intermediate acting insulins are the MPH and Lente. Next, you have your long-acting insulin. So these insulins are going to be used to provide coverage typically for a full day. And these are also, again, typically paired with a rapid or short-acting insulin. And they're going to be cloudy insulins. So typical onset is going to be anywhere from 4 to 6 hours. Peak onset is between 6 and 20 hours. And the duration of action is between 20 and 26 hours. And your common long-acting insulins are going to be Ultralenti, Levemir, Lantus, or Glargine. And the last type of insulin is your premix combos of intermediate and short-acting. So these insulins are typically given twice a day before meals. Their onset is anywhere from 30 to 60 minutes. The peak time varies between 30 minutes to 12 hours, depending on which type of insulin it is. And they have a total duration of 10 to 16 hours. And the most common premix combos are the 70-30 mixes of Humulin, Novolin, or Novolog, the 50-50 mix of Humulin, and the 75-25 mix of Humulog. So when you're mixing insulins, this is really important to remember. You always want to make sure that you're drawing up the clear insulins before the cloudy insulins. So remember, clear and fast before cloudy and long. And if you want all of my insulin administration cheat sheets, be sure to join my UNursity community, and you'll be able to download my endocrine system digital bundle until the end of this month. I'll have a link in the description below on how to join today for free. Make sure you come back around tomorrow because I'm going to be breaking down some endocrine NCLEX style questions. And that concludes the end of this lesson. I hope that you found this information extremely valuable and it made you just a little more confident as you prepare to take your NCLEX or your next nursing school exam. I just want to thank you all again so much, Lifesavers, for tuning in today. My name is Nurse Kelly Tyrrell, and I help nurses feel more confident, increase their test scores, and retain what they don't remember in nursing school. Speaking of, are you a nursing student or soon to be or ready to take your NCLEX? If so, have you joined my online student community yet? If not, then what are you waiting for? The UNursity community is a complete nursing resource hub all at your fingertips. Inside, you can expect to receive coaching, community, and content. You'll get daily coaching with your mobile mentor, me, Nurse Kelly Tyrrell. You'll also receive access to weekly educational videos that you can watch months before they even publish to YouTube. You'll also get exclusive printable digital downloads like worksheets, quizzes, flashcards, infographics, cheat sheets, skills checklists, and more. And if this video helped you in any way, be sure to give it a thumbs up. Also, don't forget to smash that subscribe button and click that notification bell so you don't miss out on my upcoming content. Also, if you can do me a favor and drop me a comment below, let me know where you're at with your nursing journey. I'd love to just say hi and connect with you. Also, make sure you click that share icon to spread the word and encourage a fellow aspiring nurse. And last but not least, when you are ready to take your NCLEX, be sure to check out my NCLEX and Chill review, where I review detailed test-taking strategies and cover every major topic that you can expect to find on the NCLEX. If you want to have that unfair advantage and pass your NCLEX on your very next attempt, be sure to click the link in the description box below. Not ready to end the study sesh yet? Well, you are in luck, because if you stick around, you can watch more of my videos coming at you in 3, 2, 1. Bye, lifesavers.